This is a right primary surgery for otosclerosis. What you can see here is the clear exposure. This is why I just put it online. It's very nice picture. We have a right here, so this is 12 o'clock, 3 o'clock, 6 and 9 o'clock. And you see the tympanic membrane here. We have a clear exposure of at least the posterior half of the tympanic membrane. There's a little bit of exostosis here. So I will start using the same type of instrument running from 6 to 12 with the round knife. And you see the distal tip of this round knife is slightly bent in order to reach the inferior and superior angle more easily. And I'm going to use now the smooth elevator. You see the position of the sucker, which is posterior to the elevator, in order to avoid making any tear. Ciseaux, s'il vous plaît. So the plan is to elevate the flap until I reach the annulus, and then opening up the middle ear mucosa, elevating the annulus. So as you can see, I'm following a kind of horizontal line. I think I have some maybe exostosis also here. So we have to take care of this exostosis not to make any tear. So I need to do it very gently here with the skin, following the bone, always in contact with the bone. At the moment I'm using a 1.2 millimeter diameter sucker. There we go. I think it's pretty close to the annulus now. As you can see, we have the vision of the annulus, and it's going to be fine because we can see the mucosa of the middle ear canal. So now I'm going to open up the middle ear cleft. You see here the annulus, the mucosa here. So I'm going to open up the mucosa here, elevate the mucosa, and the opening the mucosa and elevating the flap. And we are a clear exposure of the round window, which is not the good one, of course. I want to see the oval window, and you can see tête en déclive, a little bit of the incus and stapes. Tête en déclive, encore. Stop, montez la table un petit peu. But of course this is not safe enough, so I need to expose the facial nerve. Stop. So we have a clear vision of the incus here and the stapes tendon. This is the chorda tympani, which I try to preserve. I need to do a bony rim resection here. And you can see here the promontory, the round window niche. Okay. Correct. So I will use the curette to do the bony rim resection, but we have some exostosis here, which I want to remove also with the curette. This will help me to move on and to move the instrument within the middle ear cleft. So I reduce this thickness of the exostosis here. And I'm going to do now the bony rim resection until I will have a clear exposure, which means that I will be able to see the facial nerve, to expose the facial nerve, and the pyramidal process of the stapes tendon on the right. These are the two landmarks. Calmez, s'il vous plaît. Now you see the chorda here. All right. Curette, encore. Après, vous me donnerez le crochet pour le canal de la corde. So we can see a little bit of the facial nerve of the fallopian canal, but I prefer to increase the size of the bony rim resection. I'm going to open up the canal of the chorda tympani to see if I can. Yeah, you can see I had elevated a little bit more the chord tympani. Curette, encore. So I have part of big bone underneath the chord tympani, so I want to remove that. There's a kind of exostosis coming into the middle ear, I think, a little bit, because it's pretty thick. Now that is better. La gauche, s'il vous plaît. And so I'm going to use the chisels to finalize the bone resection here. Allez-y. Oui, 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 oui. Crochet out. Alright, there's some residual bone here which I need to remove, and I think after that we will have a good exposure and safe enough to continue the procedure. Alright, it's nearly done. I think I need to remove this piece of bone here. You see the chord tympani which has been preserved, but sometimes even when we preserve a chord tympani, correct, we still have some taste disturbance, so it's pretty strange. We never know about that. So we try to do our best, but we never know. Okay, good. Now the exposure is clear and fine. Calmez, s'il vous plaît. So we can see here the facial nerve on the left, coming in a minute with the needle. So we have a clear vision of the facial nerve here, which is not dehiscent, and the promontory, the posterior crus, and the stapes head here. So we're gonna first separate the incus from the stapes prior checking the ossicular chain mobility separately, the incus from the stapes. So this is why I always prefer to separate the incus from the stapes. I'm going to check this is, you can see the joint if I pull a little bit the incus like this. So I know the joint will be here. So I use this joint knife, triangular shape as you can see, with a fine distal tip. Okay, this is done now, and I'm going to check now malleus incus first and then stapes. So malleus incus is easy. I'm just moving the malleus. So you see the incus is fine, so both malleus incus are mobile, and from the top of the head of the stapes you see a complete fixation of the stapes. Ciseaux. So I will use the micro drill to drill out the posterior crus first and then the anterior crus, in order to remove the stapes superstructure, the stapes arch, preserving at the moment the footplate, the stapes footplate. So I'm going to use now again the sucker to stabilize the superstructure while I'm drilling out the posterior crus. Changer la fraise, s'il vous plaît. I'm going to change the burr, which is not working well, so I prefer to plafond, s'il vous plaît. So I'm using usually 0.7 millimeter diameter diamond dust burr, always diamond and never a cutting one. The burr is too strong for the purpose. Alright, now I'm going to have a brand new one, so I'm going to, you can see what you can do is to place a sucker on one side, maybe between the fallopian canal and the superstructure, and then using the burr to drill out on the other side, the posterior crus. Just leaving the diamond dust doing the job by itself, without any pressure. And there's some kind of thickness of the posterior crus here, as you can see. So I don't go further, I just do it step by step, without any pressure. There we go, now it's done. Now we have a posterior crus which has been drilled out. You see the movement that you can have with the burr when you drill like this, so it's always better to drill on the other side, but sometimes you cannot. Now I'm stabilizing the anterior crus again with the sucker, and I'm drilling out the anterior crus now with the macro drill. The problem is that I'm in contact with the skin, which is difficult to avoid that because the skin is on my right. Oh, the anterior occlusal is thicker than usual. And then we go, there we go. So now I can remove the superstructure, and we have a clear exposure then after that of the footplate. There we go. Now, what I like to do, I like to flatten a little bit the posterior part of the footplate sometimes, but not in this case, not necessary. So now we have a clear exposure of the footplate. So I'm going now to measure the distance from incus to footplate using a stapes measuring rod. So I'm using this stapes measuring rod, which has, as you will see, 3 notches. Each notch corresponding to a specific length, and the lower one is 3.5, then the second one is 4, and the upper one is 4.5. And when I'm measuring now the footplate, you see the second is in front of the incus, so it's going to be 4 millimeter. I'm going to change now for a 0.7 millimeter sucker and not 0.9 anymore, because I'm going to drill out now the footplate. So there's a risk if we have a too large sucker to suck too much into the labyrinth. So it's very important to avoid that. You see there is a central part of a footplate which is thicker than the other one, so we need to do it very gently, because I don't want to dislocate the footplate. Also, as you notice, I have measured not from this thick part of the footplate, but the thinner part of the footplate. Otherwise, if I don't take this into account, then I will measure a little bit short, and then maybe we may have a short prosthesis. So you see, I am just again leaving the burr doing the job without any issue, without any pressure. I'm using here the sucker also to control the bleeding. And of course I have to take into account the breathing of the patient, so I just follow the breathing at the same time. You see how it works. All right. So I think it's nearly done. I'm going to increase the size of the zoom. It's quite of a resistant footplate, by the way. You see, it's really step by step, including with the sucker. So again, as I said, 0.7 burr and 0.7 sucker in terms of diameter both. So you see the progressive drilling out of the footplate. And I will measure again at the end, because sometimes there is some different. I don't think they will be here, but I need to check to be sure, because it's quite thick in this area. Oui, du sérum, s'il vous plaît. No, not du sérum. So I will use some saline solution to help the drilling, for the drilling. It's giving some help to perform the Fenestra. You see, it takes more time than usual, because it's quite a very strong footplate. Very hard. So I just have to do it gently, decreasing progressively the thickness of the footplate until I reach the blue line, which is the perilymphatic membrane. Step by step again. So it's becoming thinner. You see the quarter tympani, which is also dry, although I didn't make any tear on it, but it's becoming dry. But of course we need to preserve the quarter tympani, even when it's a dry one, because usually it comes back. So you see how thick it is. Un peu de sérum, s'il vous plaît. So just, we have plenty of time to do it in this case. I don't want to enlarge too much because it's not a question of obliterative footplate, but it's just a thick footplate in the center part of the footplate. It's nearly done, I think now, but still quite really resistant, like a bit of like stone, a little bit like stone. So we need to do it very, very gently, because if we do it too strongly, then there's a risk of heating the labyrinth. Okay, as you can see now it's done. We have a fenestra. There we go. We have a fenestra, a little bit of dislocation of the posterior part of the footplate, but it's good enough. And now I have a clear stapedotomy to be able to place the prosthesis. There we go. All right, let's measure again. Mesureur. So it's still 4 millimeters, so it's pretty good. Okay, and then alright, this is the vein graft which I took from the dorsal face of the hand, and we are facing now the intima of the vein. The adventitial side is opposite, and I'm taking the vein with the sucker, and I'm going to introduce the vein with the sucker and stretch the vein with the needle. You see there is some residual part of the footplate which is partially dislocated, but I don't want to remove it. We just have to keep it like this. That's what I do in this case, and the vein will help to protect the inner ear, of course, and this is going to be stick to the posterior part of the footplate, so it's going to be okay. Otherwise, if we want to remove it, then we go with a hook, and it's a risk to push everything inside the labyrinth, so it's better to keep it like this. And now everything is ready for the prosthesis. So we have 0.4 millimeter diameter Causse Teflon piston, and I'm going to cut it at 4 millimeter. You see the shaft, all made in Teflon, and I'm going to break the memory of the loop and then introducing the prosthesis. So I'm holding the shaft while I'm breaking the memory with a needle. All right. Alright, so I'm going now first to introduce the shaft within the fenestra like this, and then the loop will be passed around the incus, and I just need to cream the loop around the incus. So I think it was pretty good to show that because of this partially dislocated posterior residual part of the footplate and the way I'm dealing with this, which is, I think, the safest one. And you see him crimping the loop like this, that's enough. And now looking for the bending sign. We all remember that the piston should bend but not move. Otherwise, this is, if it's moving away from the oval window, it's a sign for a bad position or short prosthesis. You see the bending. So it's good, and now the mobility from the malleus is pretty good too. Alright, that's enough. So I'm going to reposition the tympanomeatal flap like this, and that's it. And placing now a middle cell, which I remove on the 5th day usually. Allez-y. Okay, thank you very much for watching. It's a basic case, but sometimes it's good to show something like that. The only interesting point is the footplate. So thank you very much for watching, and see you again soon. Bye bye.